All right, it looks like everything's slowed down. So let me say hello to you all and good morning. Thank you for joining us today for our panel on removing regulatory barriers to telehealth before and after COVID-19. I am Lee Spangler. I'm in charge of state government affairs for Blue Cross Blue Shield of Texas. And I am pleased to introduce to you today our panelists. First, we have Mr. Jordan Roberts, who is a healthcare policy analyst with the John Locke Foundation. And we also have Dr. Nicol Turner-Lee, who is a senior fellow and governance studies director at the Center for Technology Innovation at the Brookings Institution. Dr. Lee and Jordan recently co-authored a white paper that explores the telehealth field's impact on limiting the spread of disease and ensuring access to care during the pandemic. Importantly, the paper also lays out the opportunities and challenges ahead to ensure a thriving and efficient telehealth industry. We're going to get started with Jordan, who will provide an overview of some of the regulatory challenges identified in their white paper. Jordan, thank you very much, and let me turn it over to you.
Thanks, Lee. Yeah, and I'm gonna share my screen here. I have a few slides. Yeah, so as Lee said, my name is Jordan Roberts. I'm a health policy analyst at the John Locke Foundation, which is a state-level public policy think tank in North Carolina. And recently, Dr. Turner-Lee, myself, and another researcher from the Brookings Institute, our co-author Jack Karsten, we released this paper titled Removing Regulatory Barriers to Telehealth Before and After COVID-19. And so I'm going to walk through some of the findings that we came up with in the course of our research. So just a little bit of background on the paper. The idea for this paper started with another report by my predecessor, Catherine Restrepo. She wrote a report titled The Case Against Telemedicine Parity Laws. And basically what that report did is it profiled all of the players in telemedicine here in North Carolina and basically made the argument that there's a thriving market for telemedicine and telehealth without these parity laws. And so what we wanted to do is expand this idea to a nationwide analysis. And we wanted to look at all of the states and to understand what states are doing to regulate telehealth, what type of barriers exist, and if there's model states and any types of trends among regulating telehealth in this country. And we wanted to look at the issue from the bottom up and the top down. And what I mean by that is, from the bottom up perspective, we're talking about patients and providers. These are the people on the ground using telehealth every day, but also from the top down in the sense that the federal government and state governments also have a say in regulating how this gets used. So it's important to understand the issue from both perspectives. And that's what we tried to do in this paper is, provide a detailed explanation of what is the current environment for telehealth. And so what we started with in the paper are what we believe are 4 of the biggest current barriers to telehealth. And these are broad buckets, but, we think these really encapsulate exactly, what type of barriers that individuals are facing. The first one is reimbursement. And what I mean by this is how a provider or a doctor gets paid by, either the patient or by someone's insurer. And this is a big issue in moving forward. There's a lot of disagreement about how reimbursement should be done. From the provider perspective, these providers are looking to get reimbursed for providing similar services in person over telehealth. And so from their perspective, if the reimbursement is inadequate, they may be dissuaded from investing in the technology needed to provide telehealth in their practices. And, especially with smaller and rural practices, this could be an issue. From the insurer perspective, this is when we really get into the weeds of what do we classify as a visit to the doctor? Is a telehealth visit the same thing as whether or not you go into the doctor's office, the brick and mortar office? So from an insurer perspective, it's about how much should we be reimbursing doctors for providing services over telehealth. And then from the insured's perspective, if an insurer and a provider, may not agree on certain reimbursement policies, then maybe the provider doesn't offer the same benefits that are in the insured's plan, and maybe the benefit plans chooses not to cover telehealth because they know that there may not be adequate reimbursement in this space. So reimbursement's a big barrier right now. Second is licensure. In my opinion, one of the greatest benefits of telehealth is that we can connect patients to doctors over large, vast distances. And, as many of you probably know, in order to practice medicine in a state, you must obtain a state license. And so, what we essentially have done in the United States is created these 50 little hubs of where you can provide care. And that state license is what dictates who can access care and who can provide care. And so, like we saw during COVID, we opened up a lot of these laws, allowed doctors to practice across state lines. So, as we look forward to the benefits of telemedicine, connecting people over long distances, licensure certainly stands in the way because we're limiting the patient's access to a provider only to those who are licensed in the state which they reside. So as we move forward, looking at how we can knock down these barriers to connecting people over great distances is certainly a barrier. The next one is rural broadband. And, I'm from North Carolina. Texas and North Carolina have very large rural populaces. We have large medical deserts. We have provider shortages. And so, one way to address those shortages is through telehealth. But your connectivity or the value of telehealth is only as good as your ability to connect to it. And so, as we think about rural healthcare reform, because in my opinion, the current model of rural healthcare isn't sustainable. And I think telehealth has a lot of opportunities to, really bridge the gap between what our rural communities have access to and what our more urban communities have access to. So rural broadband is an essential part of this, and it's a huge barrier that I know a lot of areas in Texas face, and it's the same thing in my home state of North Carolina. So figuring out how we can bring broadband out to individuals who may be in more rural and secluded areas is a key part of this discussion. The fourth barrier that we discussed are existing health disparities. And what I mean by this is we know that not everybody has equal access to the healthcare system. Not everybody has an equal experience and, may have different levels of trust with the healthcare system. And this has certainly been exacerbated by the COVID-19 pandemic. So when we talk about these populations that have not had a great relationship with the healthcare system, we can think about how telehealth can help bridge that gap, but there's a lot of work to be done to build up trust and to, provide experience and make people that, may traditionally not have had as much access to the healthcare system, make it easier for them to do so through telehealth, but we need to understand it in light of these existing health disparities. So these are the four big barriers that we see. Obviously, you can get a lot more into the weeds on all of these, but this is how we saw these main barriers. So, we'll talk about parity laws a lot, and obviously this is, kind of where the motivation and inspiration for this paper came from. But, one of the things we wanted to do is really nail down on how are parity laws affecting the uptake of telehealth. And, this depends on who you ask. If you ask an insurer, if you ask a provider, it's going to depend on, their interests. And so what we wanted to do, and this is this chart you see, is directly from our paper. What we wanted to do is illustrate the incongruencies in state telehealth parity laws. And as you can see from this chart, almost every state has different telehealth parity laws. Some have none, some have partial coverage, some have full coverage, and some have coverage and payment. And so what we see is just a giant patchwork of, differing regulations. And, we believe this is a big hindrance to the further adoption, because as providers and insurers want to go into a market and provide these benefits, these are obstacles. They have to, make sure they're compliant with all of these regulations. And so we see this just as really incompatible with the future of a very well adopted telehealth model where there's different laws in each state. Also, as most of fully insured versus self-insured plans. Self-insured plans are essentially regulated by the federal government, and the federal regulations preempt all of the state regulations. So, these parity laws have the stated goal of increasing adoption, but we know that they're, again, not applied uniformly across the board to all insurance products. So this is another patchwork regulation that we see. And also Medicaid and Medicare, regulated from the federal government, Medicare, and then mostly Medicaid, but it's administered at the state level. So each state's Medicaid policy may have different regulations and different requirements. And then as we see more of the shift to managed care organizations, how do these laws impact these benefit plans? And is there a way to make them better to where we can have more adoption and more easy use for patients and providers? So this is kind of a broad overview of some of these barriers and some of the issues that we think we need to address as we move forward. And so, yeah, I'll turn it back over to Lee now.
Thank you very much. And it's easy enough. Thank you, Jordan, because I get to turn it over to Dr. Lee. Dr. Lee, go ahead and present the issues that you'd like to highlight from your paper.
Well, thank you, Lee, and thank you, Jordan. As Jordan mentioned, I'm at the Brookings Institution, and we had this really fantastic partnership with the John Locke Foundation in looking at this issue of telehealth, which I think, for those of you who haven't read the paper, please go get it. It's available on both of our websites. I want to say something before I jump into some of the findings and sort of tag along with Jordan talked about. I mean, this is not a new issue. Telehealth and telemedicine have been around for quite some time. I'm not going to age myself, but there was a certain legislator in Wilson, North Carolina, when I first came into the policy space that was particularly interested in how to serve rural communities using telehealth. After that, about 10 years ago, and talking to that congressman, I had the opportunity over the course of years to actually follow companies, if some of you remember, that had doctors in boxes that were dependent upon a broadband connection to deliver services. And I think the most poignant moment I've had in telehealth was sitting in Anchorage, Alaska, and watching a telehealth service back maybe the same 10-year window where they were administering dermatological care to patients who could not get to the city. Fast forward 5 years after some of those demonstrations, we're seeing great places like the University of South Carolina doing stroke care via telehealth. We're now seeing, institution of telehealth in various aspects of secondary care, but something major happened while we were writing this paper, and that was COVID-19. And so our team we were looking at how do you remove the federal and state barriers to adoption. And now we've actually shifted this conversation that has previously been focused on reimbursement to utilization. And so I would like to say, when we first came out with this paper, Lee, that we used to talk about this as a 3-month national pilot. After the administration and Medicare, Medicaid was relaxed to allow for greater adoption of telehealth and telemedicine, I think some of us didn't know what to do because for decades we were working on this issue. But what we have actually seen in the last 6 to 7 months is that this is becoming more of the norm and the standard. So as Jordan talked about, we were particularly interested in the work of his colleagues around how do you make this more ubiquitous and how do you remove the regulatory compliance barriers that may get in the way at both the state and the federal level so more people can benefit. So I'm just going to share with you just briefly some of the recommendations, and then we can hopefully jump into Q&A. I mean, first and foremost, I think we have collected enough data during COVID-19 that actually should convince us that this is not about a reimbursement model anymore. This is really about the adoption or the necessary adoption of telehealth because social distancing made it that we had to see our doctors in that manner. The inability to go to your clinician and basically see that person physically was made virtually impossible, right? As a result of the infectious nature of the virus. And to this day, there are still particular harms associated with that. What does that mean? We actually have a lot of data about these visits, and we had a panel when we first put out the paper with the American Medical Association, and I hope they are still doing this, collecting the data on the eligible use cases or the types of use cases on telehealth and telemedicine will be critically important, which is one of our first recommendations. Without the data, we will not be able to see where the volume or where the incentives are so that we can continue this. That's first and foremost. I think the second thing that we actually also suggest in the paper is that we need to continue the regulatory flexibility of adopting and using telehealth. Again, I had to share my story earlier to let you know I come from a place where we've been talking about this for decades. And now with the flip of a switch, we're actually seeing telehealth and telemedicine being able to be utilized by doctors, by patients in ways that I think should stick around. I mean, just a couple of weeks ago, the administration actually put out that they hope that that is the case as well. And there's a bipartisan letter that is circulating on the Hill that is suggesting that we need to continue to adopt telehealth and telemedicine. So the future of this, however, and we say this in the paper, is really not dependent on what it looks like today. It's really dependent on what it looks like going forward. And so I think if we want to not find ourselves sort of relitigating, redebating some of the merits that we're finding under this pandemic, it's important that we actually build in the flexibility that is not just for the now or tomorrow, but for the future. Because I think all of us can agree that the technology is basically outbeating our pace of policymaking. So we should do something differently there, which is what we suggest in the paper. I think the other thing we suggest in the paper as a third recommendation is now we're actually seeing telehealth used for primary care. And that's really significant, and it relates in part to the parity conversation. The COVID-19 pandemic, essentially, and I love the way Jordan articulated this as we were writing the paper, created these artificial volumes for doctors. Whereas before, doctors were not necessarily incentivized or reimbursed for these services. Under COVID-19, we saw volumes of people now using these services. We also have seen people use the service, not the way I saw it years ago in terms of a secondary or tertiary care, but for primary care, which is, I think, for many of us, one of the ways we would have liked to see telehealth used, because it does a couple of things. It eases the distress on doctors who have to take in patients for primary care functions that may be non-essential in terms of your vitals. But then two, it eases the stress on hospitals who are often seen as the primary care doctor by medically underserved communities. And so from the paper, we actually make the suggestion that we should probably look at primary care as one of the impetus for keeping telehealth, because that allows for us to reduce some of the service redundancies that we have actually seen, and probably some of the payment redundancies as well. It also will help in keeping the volumes, because it's not to say that, when the pandemic is finally over, quote unquote, that people won't rush back to their doctor, but keeping it in the primary care space, I think, is really important to incentivize medical practitioners to continue this best practice. This goes to the state parity laws. What was interesting during COVID-19, and this is the next recommendation that we propose, is that many states use the parity laws as the indicator or the floor for reimbursement. And I think that was probably right? Because we didn't have to go back and renegotiate the payment schedules. However, as Jordan has indicated, the parity laws prior to the pandemic were very disparate in terms of state adoption. And they also, in some states, created barriers to innovation and barriers to flexibility when it came to the payment schedules back to doctors. So we actually suggest in the paper that we really need to get rid of state parity laws from the extent to which it actually limits innovation or limits the incentives for doctors to continue the practice. If there are some states, as Jordan has said, that are actually implementing them and some that are not, we're sort of setting ourselves up, as we've suggested in the paper, for this patchwork of various rules and regulations that may actually stifle our future use of this technology. And I think that's really important because, again, as I do my work, and I'm writing a book on the U.S. digital divide, by the way, shameless plug, Lee, I had to get it in there somewhere. But the key thing is, digital has now become really important, folks, right? It was not that important maybe right before the pandemic, but having access has actually re-engineered how we do just very basic perfunctory rules in terms of things like going to the doctor. And so I think it's important that we also move away from disparate reimbursement systems. And then finally, I would say the medically underserved. One of the recommendations that Jordan already mentioned, so I will not repeat it, is that telehealth has to be a glide path for getting more people connected to healthcare. It's so interesting. Almost 20 years ago, when I was working in communities on digital access issues, I always imagined in my mind that we would have this technology to sort of help level the playing field for people who did not have close proximity to hospitals or actually doctors, either in the inner city or in rural areas. And now we're actually seeing this come true, particularly as we see among populations of color, African Americans. I just read a very glaring statistic that, they're sort of the third, COVID-19 is the third leading cause of death. And that's coupled with all of the chronic conditions that are overlaid on these populations that cost not only the medical system millions of dollars, but it also costs the well-being of these communities. An interesting statistic for this community as well, as we do this presentation, Black kids are probably, I think it's like 5 times more likely to be infected by COVID, and Hispanic kids 8 times more likely, given the likelihood of their parents having this. So my friends, we are headed towards an Armageddon when it comes to healthcare and the management of disease. So we need tools like telehealth to help us maintain distancing, but to ensure that these communities are, again, getting the proper care that they need to either get well or stay better. And those chronic conditions added on top of this disease has made this even more critical. And that's why I would just end with this in terms of our recommendations. Any of this stuff will not work if it is compromised in any way from a cybersecurity perspective, from a privacy perspective, or broadband insecurity perspective. And so we do say at the end of the paper that having these conversations with our doctors encrypted matters. Being able to ensure that these interactions still fall in the compliance of HIPAA matters. And then ensuring that we have broadband that is secure and safe and resilient so that all people can benefit also matters. And I just want to close, Lee, because I do a lot of stuff in digital, and Jordan knows this, and I keep thinking about, as I think about telehealth, sort of like the comparison to what we're seeing with educational inequity. It's like we want every kid to be virtual, but yet they don't have the tools. And I think as we continue this conversation, I've since written more about this in terms of telehealth becoming more permanent, we also have to ensure that these communities, all of us, have the tools to get this right. It's almost like the digital health toolkit, right? That we need to be able to engage these services in a more meaningful way. So as when we wrote the paper, 3 months has now become 7 months. We think we're actually on to something pretty good here in terms of making sure that telehealth doesn't go away, because if my older mother can now enjoy the fact with herself being immune compromised that she can speak to her doctor on a pretty regular basis, I think I'm hooked. That we need to do something quickly to ensure that our communities across this country have equitable access to healthcare.
Well, thank you very much, Dr. Lee. Greatly appreciate that. And I'd like to remind everybody, if you have any Q&As, go ahead and put it into the Q&A section so that we can get it to our speakers. But the fun part about being a moderator is I get to ask my questions first. And so I'm by education and experience a health lawyer. And very early in my career, I worked at our medical board, which licenses physicians as well as physician assistants. So Jordan, I'd like to maybe toss an issue to you regarding licensure. When you say licensure to a health lawyer, I'm thinking, well, is Jordan talking about reciprocity, just recognizing a license from another state? Is he talking about an expedited license in Texas that might be quick to get but limited to telehealth? Or are you talking about a congressional bill that actually creates a federal license for telehealth? So I thought I'd ask you that. What do you mean by that? And then what examples across the country have you seen that you think might be good to emulate?
Yeah, so in my opinion, the national licensure is not the right way to go about this. Healthcare is local, and we should leave the local state entities to establish standards and administer or control how that's administered. But what I think, it's just, there's so many examples across occupational licensing where, we certainly want to ensure that these professionals are well trained, don't have any, criminal background, things like that. But what we need to do is ensure that they can treat patients as they wish. And so I think Arizona has the gold standard of a bill. It's not a reciprocity, but it's a universal recognition of licensure. So if someone outside of Arizona is licensed in their state to as a nurse practitioner, for example, and they move into Arizona, it's an expedited process to where Arizona can quickly check boxes to say, yes, this person is in good standing with their state, so we should admit them to allow them to practice very easily. And so I absolutely think it should still stay with the states, but I think states should do more to make it easier, because like we know, crossing over a state borderline, you don't lose any of your skills. And so, we shouldn't, these artificial barriers at state lines, we should just make it easier for folks that are licensed in one state to be able to practice in another state if they so choose.
Thank you very much. Very interesting. And as you can hear in the background, my phone is ringing. So sorry about that. All I need now is some dogs barking, and I think it'd be perfect for I'd hit a hat trick in terms of Zoom meetings. Dr. Lee, you have a particular interest, and actually I do too, in regard to disparities in telehealth. I mean, even in the in-person setting, it has been widely recognized that there is disparities in how healthcare is delivered, whether you're talking urban, rural, or you're talking about cultures and even ageism, if you will, the ability. I mean, one of the things we did in Texas is we abided by the federal relaxation, and everyone can use FaceTime rather than having to log on to a computer to get that video talk. But can you maybe expand a little bit more in what you see as maybe any particular challenges that telehealth might introduce in terms of healthcare disparities, or maybe unique solutions that we don't really think about that telehealth might bring to the issue of healthcare disparities? I'll let you just strike on that one more time.
No, I love that question, and you're welcome to pick up the phone, Lee, if you have to. We're okay with it. I love that question because, again, giving people some background on how I got interested in this, part of what we're seeing in terms of certain communities is this like overpiling of chronic conditions that are largely due to a series of factors, right? The density of housing, the lack of nutritious food sources, the lack of trust, right, in medical providers, the history or the structural history, I'm a sociologist, of distrust that has come with, the ill treatment of certain groups of color when it came to vaccinations or care. And then just the insufficient proximity to care as well as quality care institutions. I mean, all of these compiled together have created the type of medical vulnerabilities that we're actually seeing, not just among people of color, but among rural areas, as well as among the elderly population. I am one of those people, I have to personally say, that lost 2 family members and COVID-19 in New York who were medically challenged and living in nursing homes. And so when you start to overlay that, and then you start to look at some of the systemic inequalities that we're dealing with as a country, right? Whether it's racial inequity or whether it's poverty, we have this opportunity through telehealth to potentially get it right by delivering the service directly to the patient. But I want to start with what you said. The challenge, honestly, is, does every patient in America have equal access to broadband? And that we know is not the case. There are 18 million people in this country that still do not have a connection. And out of those people without a home broadband connection, for example, they may not have a device that is internet enabled, as you mentioned. So I was actually happy to see some of the provisions accept a phone call in some cases as a doctor's visit. You add on top of that the inability of individuals to understand the necessity of real-time interaction. Years ago, when we had SMS text, right, we were able to do things like, text mothers who for prenatal care, remind them of their doctor's visits. The same type of technologies that can actually be applied today, and even better because we've improved upon the process. But without broadband, you cannot get it. And if you have a connection that is not necessarily strong in signals, there are things that you also cannot do. Like this goes beyond the scope of this discussion, but like surgical surgeries, right? There are some places that are actually administering via remote care surgeries, but that really depends on the stability of that connection, which is why I'm very hopeful about 5G technology. That, in addition to the fact that, and I'll throw this out as a disadvantage or an area that we have to also look at, is this new space of emerging technologies where, and Jordan and I did a panel on this, where the accumulation of health outcomes becomes surveilled. And they actually create another bias for certain communities where we may actually see triggers for why they are high risk in terms of insurability, or we may see triggers in terms of the types of care and treatment we can provide based on the limitations of our current healthcare system and reimbursement. So Lee, I mean, there's a pile of stuff that goes with that. But the challenge, and one of the reasons why I was really excited to write the paper with the John Locke Foundation, is that we have to start depending upon this innovation to sort of open up the channels for us to deliver these types of healthcare options to people who are displaced or from the system, or may not have the means to actually get that type of care. I'll give you a really great example. The other day I was in Walmart shopping, and I saw these people set up with like a clinic within the fitting room area of Walmart. And my nosy self kind of pushed my cart back to see what they were doing. And they were giving out free flu shots. And of course, as a person who already has insurance, I asked the lady, do I have to pay? And she said, well, if you have insurance, you don't. And if you don't have insurance, you don't have to pay. And I got my flu shot. And you know how important that is to have that at this time. And I thought about this concept that Jordan, Jack, and myself have been pushing, and my colleague Niam at Brookings, around pushing telehealth more permanent. Could you imagine, Lee, to your point, what we would be able to do if we were able to give access to a device? Maybe it's a phone, maybe it's something else. If we were able to have broadband available to families, think about the type of savings that we could have in healthcare. Think about the likelihood to have immediate attention to those chronic conditions like heart, pulmonary care, or diabetes. Think about what we would be able to do to sort of stave off the rising number of mortality or morbidity among women of color when it comes to, pregnancy. Just by having that connection helped people in nursing homes stay connected in terms of their mental disposition during this crisis, or being able to give, like my mother who has MDS, the ability to have immediate care for her not to have to travel out and be high risk in the environment that she's in. So I'm a huge proponent of how we do this. What I'm always concerned about, and I think we bring this up in the paper, is how do you pay for it? Because this, again, is an area that is not a direct allocation from the National Treasury, or, we're still fighting how to pay for the 18 million people to get online. And so I think as we continue to have these conversations, I would implore companies like yours to think about what could be done to actually underwrite this type of connectivity for some of those chronically ill patients that will in turn save you money, right? Versus take away money if we were able to stay connected to the medically underserved. So just something to think about. And I'm writing a book on this, and I'm kind of toying with that as one of my use cases, because I really think we have to figure out a way to move digital to the top and use it to solve these types of problems that are only get worse if we actually don't address them.
Excellent. Thank you. Thank you very much. And we'll be looking for your book. I'm sure you'll come back when it actually comes out.
I will.
So thank you both very, very much. And thank you everyone for attending this panel. I enjoyed it. Thank you again. Our next session begins just in a minute or two at 11:30. So please visit the forum webpage in order to click on the appropriate link. So thank you very much, and you all have a good morning and afternoon.